Good afternoon, everybody. Thank you for coming and bearing through some hurricane winds, it sounds like, to get here, so I appreciate that. We do welcome you to the Community Health Endowment, and we're proud and privileged to serve the community. And if you'd like to know more about us, you could read about it in our annual report, or we'd be happy to talk to you at any time afterwards. We are governed by a 15-member board of trustees. Two of those members are joining us today. Carol Burt is right here. You can raise your hand. Mike Molvar. And our former board chair, Janet Coleman, is here. And Lauren Roberts. Of course, I saw Lauren come in at the last minute, too. I forgot to write her name down. So you're welcome to talk to any of those folks about what we do here as well. So we are here for our third installment of our My Story series. And we continued this. We're not one to kind of do the same thing again, but it's been so popular. We have decided to continue with it and to share some more stories about people who live and work in our community and have really insightful stories to tell. So we have 3 more events in this series. You can read about them in the brochure on your chair. But we'll be covering the topic of suicide survivors, or individuals who have had a loved one or someone close to them commit suicide. And that, of course, is a hot topic in our community now because of a series of very tragic events. And so we're hoping to hear from folks who have experienced that firsthand from someone that they love, and to hear about what our community can do to respond. We're also going to be talking about homelessness, people who've actually experienced homelessness, what that was like for them, how the community responded to them, how we can do better to assist them. And so that's going to be an excellent opportunity to hear personal stories as well. And then in May, I believe on May 20th, we will be hearing about mental health and the challenges faced by individuals who struggle with mental health issues, but who also parent children with mental health issues. And so we expect all of those to be incredibly interesting, and we welcome you back to any of those. But now on to today. It's my privilege to welcome these folks to talk about an event or a set of events that have taken the spotlight in recent history here. That is the case of Ebola patients coming to Nebraska. But even beyond that, how Lincoln is prepared to address infectious disease challenges. You know, in my old life, I was an epidemiologist. Greg Warden and I worked together. Tim and I worked together in that field. And constantly looking at outbreaks and situations where things like that were appearing in our community. And it is an incredible challenge to think about how to address those, especially as they're changing and morphing into new and different strains all of the time. So we're going to be talking about that. And I want to introduce you to our panelists. Our first is Kate Boulter. Kate came down from Omaha today. She is an RN, the lead RN, in the Nebraska Biocontainment unit, and she has been there since it opened in 2005. She's responsible for staff training and coordinating the patient care when the unit is activated. So she is on the front line and definitely has a story to tell. She is responsible for coordinating and chairing the staff meetings, the drills, developing and updating the unit's policies and protocols. And she also serves on the Nebraska Biocontainment Unit leadership team. So she is certainly in the know, and we're excited to hear about her story, but also to see some of the things that she brought to share with us today. We'll also be hearing from Dr. Wade Fornander, who is a physician here in Lincoln at Prairie Lake Family Medicine, which is one of only 3 clinics in Lincoln to receive the highest level of recognition possible for providing patient-centered medical homes. The clinic emphasizes preventive health and reviews every patient's vaccination status at every visit. He sees patients all the way from newborns to nursing home residents, and his clinic is really focused on taking care of the whole patient and keeping them as healthy as possible. He previously practiced in McCook and spent 3 years teaching family medicine residents at the Lincoln Family Medical or Medicine program. So we are excited to hear about his perspective as a physician who lives and works and treats patients in Lincoln. And I will also tell you as an aside that I know that personally he's an incredible runner and triathlete. He won't tell you that, but I can tell you that because I've seen him in action. And our moderator today is an old friend of mine. I can say old, can I, Tim? Is that all right?
Yeah, go ahead.
Tim Timmons. Tim has been through all of the layers of leadership at the Lincoln-Lancaster County Health Department in the communicable disease area. He has been a field nurse, a field supervisor, a clinic supervisor in immunizations and STDs and the AIDS services, and he assumed his current position to address issues like bioterrorism threats, including anthrax in 2001, SARS in 2003, a flu pandemic in 2009, and most recently Ebola. So if there's a guy to know about infectious disease in our community, it is certainly Tim. So I think that this group represents an incredible amount of knowledge. I know they will share that with you today, and thank you very much for being here.
Thanks for coming. I think we got an interesting program for you. We're going to, certainly is timely in terms of what's going on with Ebola, but also we've got measles, we've got whooping cough, we've got all kinds of things. And so this is certainly a timely topic and an interesting topic. I think you'll learn a lot from this. What we're going to do is work our way down through the panel with Kay going first, dealing with Ebola. I tell you, a year ago, if somebody would have said we would have been dealing with Ebola, I would have said, no way. In fact, I used to kid with staff when they were taking off, say, call me if you need me. I said, well, I won't call you unless Ebola shows up. Well, we don't say that anymore, because if I call you now, it's because Ebola showed up. But anyway, so you never know what's going to show up next, and that's what makes it interesting. So with that, I'm going to turn it over to Kate and let her go ahead and begin.
All right. Hi. I just want to say thank you very much for inviting me down here. There's nothing more that I like to talk about than our unit. And what I want to do is give you a little history about how the unit came to Nebraska and how we're the only state that really has a unit like ours. After 9/11, Homeland Security was a new agency that the government set up, and with that came some federal funding for each state. And at that time, they wanted each state to increase their negative pressure beds in their hospitals. A little bit later, there was a case of monkeypox in Illinois that you may or may not know about. And what that case showed us was that doctors and nurses will refuse to take care of patients if they feel like their life is in jeopardy. And then, of course, there was SARS. And SARS became a nosocomial infection, meaning it became a hospital-acquired infection. And in fact, most of the people that got sick from SARS were the healthcare workers in both Asia and in Canada. So with the money that was coming in with Homeland Security, our chief of infectious diseases at the time, his name is Dr. Smith, Philip Smith, he thought, what we need is not just more negative pressure rooms in the hospitals, because we already have that. We have plenty. But what we really need is an entire unit that's negative pressure, meaning that when you walk into the unit, the air comes with you and it's being sucked in, and then the air that gets sucked into the unit goes through a filter, and I'll explain a little bit more about that to you later. And we also need staff who are willing and trained to take care of these type of patients that we'd put in there. So he proposed the idea to the state health department. They liked it, and a partnership developed. And the partnership is between Nebraska Medicine, which is the hospital in Omaha, the University of Nebraska Medical Center in Omaha, and also the state of Nebraska. So what you really have is a state asset. So although the unit is in Nebraska Medicine, it's a joint decision as to how the unit opens between the state health director and Dr. Smith. They two have to come to an agreement to put the patient in there. This photo here was taken on March 8th, 2005, so almost 10 years ago. And it shows that partnership because you've got the chief of the hospital, and then you've got Julie Gerberding, who was the Secretary for Health and Human Services at the time. You also see the governor there and the chancellor of the university. So that one picture ties in the entire partnership. So be proud. When we knew that we had the money to start putting the unit together, we had to find out, what is it we need? So Dr. Smith, and that's him standing there next to a sign that says USAMRIID. And USAMRIID is the U.S. Army's Infectious Disease Institute in Maryland. And they already had a unit that he went to, and he had a look at some of the features that they had. The unit itself is closed now. It's a little outdated. But what it did have, you see, this pointer doesn't very work, but if you can see where the arrow's pointing to at the top, it says TP. And if you look at the bottom arrow, it's pointing to a metal plate. That is a unit that they have where they take that metal plate off the wall, they would bring the patients in that way, and then they would slam that plate shut again, and then bolt it, and they called it the slammer because of that. So we didn't think we quite wanted that, but we wanted to know all the other things. So they had an autoclave, meaning they could sterilize things before it left the unit. They had personal protective equipment, and I'll refer to that as PPE in the future. But they had specialized PPE. They also had rooms that were capable of giving ICU standard of care, and they had this, looks like a tent, a negative air pressure capsule for transporting patients. So these are some of the things that we took, and we copied that. So we have on the right there, you see our autoclave. In the middle is special packaging procedures for things like labs that can't go through an autoclave. So you can't sterilize that, or otherwise, you're not going to have much of a blood culture to do. And then on the left, you've got our dunk tank, which we used to send our labs through. So it would have to we would specially package it, clean the package, and then put it through the dunk tank, which was filled with a disinfectant, and it would have to sit there for 10 minutes. And in that way, we made sure that we were never going to pass any germs out into the community on packages. We also had our own patient transport system. Up on the top there, you see that's the isopod. That's how we thought we would always bring our patients in. And then on the bottom right, we also have another material, and I brought some of that with you. That can be used for packaging biohazard waste, and that would include a deceased body. We have rooms. Our rooms were 2-bed units, or 2 beds in each rooms. We have specialized PPE, and over the years we've gone through different styles of PPE on what we think would be best to wear. This is our slammer. So that's actually a double door system where there's a door on the other side of that, and the two of them can open at the same time. So when the outside door opens, the patient comes in, that door closes, and then we can open the inside door. And it's an airlock to make sure that none of the air is able to get from the unit out into the hallway of the hospital. We have 20 air exchanges an hour, and the air that is in the unit is not recirculated. So it comes in through a special vent into the unit, and then it gets sucked out through a whole network of ductwork, which then takes the air into a HEPA filter, which filters the air to make sure that when we exhaust the air from the unit into the community, that there's no bacteria or viruses in it. Okay, our air always flows from clean to dirty, meaning and it's a negative pressure gradient. So we have the rooms are more negative than the hallway, so always air is being pulled into there. I tried an experiment once where I put a tissue in the hallway, and by the end of that day, that tissue had been sucked into the room, so I know for sure it really works. I think, though, our biggest asset is our staff. And our staff are highly trained. They all work at Nebraska Medicine in different areas of the hospital. They all know very well how to operate in the unit, and they meticulously adhere to all of our protocols. This is what the unit looks like. So you can see we've got a staff entrance, the main entrance, which is for the patient. It's also for equipment and supplies that we might need. We have a clean utility room, which is on the other side of the dirty utility room, and that's where the autoclave is. So when we put items into the autoclave to sterilize it, it can open on the other side, and someone who's clean and hasn't been around the patient or in the unit is able to take it out, and then it goes for further processing. We have a nurse's station, and you'll see in this picture, you can see where the patient rooms are at the very back of the unit. So for Ebola, we've realized that we can only be a 2-bed unit. Even though we've got 5 rooms capable of putting 2 beds into it, we can really only handle 2 patients at a time. And that's really because we've got to have a room where we can store waste. So things like our PPE, when we take that off, we don't want that just piling up in a corner until it can get to the autoclave. So we needed to have a dirty room where we can keep it all neat and tidy. We also have a lab. That whole process I was telling you about earlier with the dunk tank, that took about 40 minutes for us to just get the lab out of the unit, never mind run the tests. So, and that's really, when it comes to patient care, and you've got a critically sick patient, that's just not very good at all. So we put a lab in, and it has a biological safety cabinet is what it's called. And our lab people are able to come from the public health lab and come into the unit and run all our tests for us. We also need a clean room, and that clean room is for staging clean equipment, so that when we know we're getting a patient, we put things in there like the x-ray machine and the ultrasound machine, things that are needed for patient care, but we may not need it for the patient. So we put it in there, and it stays there until it's needed. If it gets used, it stays in the dirty room until we can decontaminate it after the patient has discharged. This is some pictures of us operating in the past. So this is us doing a drill and practicing. A lot different from the pictures you'll see in the media of how we are when we have a patient. For the past 10 years, we've been doing drills, we've been doing meetings, we've been doing some research. We understand how air flows in the room. We know how to put on our PPE and how to take it off properly, okay? And I'm going to show you a lot of pictures on all of that. We also do a lot of community training. So we bring in people from our OMERs. Once a year they come in and they learn how to use all the specialized equipment and things that they have in their own hospitals as well. Let me show them that. Another picture of us doing a drill. As you can see, still not the PPE that we've landed on. This is us doing community education with other staff from other hospitals. And this is a picture of us looking at the PPE that we had available and seeing where could things go wrong? How can we make it better? And eventually you're going to see pictures of what we have. And this is a picture of our staff teaching each other. So because we all work in different areas of the hospital, so we've got some ICU nurses, we've got nurses who work in the operating room and in PACU, we've got pediatric nurses that they're all very good at what they do, but I don't know what an ICU nurse does all the time. So they teach me, and I teach them the things that I know. And this is actually an OR nurse teaching the rest of the staff how to run the autoclave. It's not something that we normally do on a day-to-day basis. We've also learned how to work as a team. So we've done things like we've gone out to the Carol Joy Hollings camp, and we've done the high ropes courses and learned how to rely on each other. And we've also brought our families into the unit so that they can see what goes on, because it's pretty scary. It's scary for the public, and you can imagine when our families are reading what they read in the media, and they're wondering, what the heck are you doing in that unit? But you can see over on the left, one of our nurses letting her son try on some of the PPE, and on the right, that's actually my daughter, and she's been our our drill patient or pretend patient. So they're all very comfortable with it. So when we're looking at Ebola, and are you going to talk about Ebola? No. Okay. So with Ebola, understanding the disease is the biggest thing for us. So we know what the symptoms are. It comes in early, mid, and late symptoms. People who get exposed to Ebola, the incubation period is usually between 2 and 21 days, average between 8 and 10 days. And we do see all these things. So the sudden onset of fever, I can tell you that or each of our patients that were able to talk to us, they told us that they knew exactly when they got sick. It's sudden onset fever. They were fine one minute, and the next minute they had such a high fever and they did not feel very well. The fatigue is profound. I don't think I've ever taken care of patients who look like they are normally very fit and strong, and their weakness is incredible. And even after they discharge, they're still very, very, very weak and don't have very much stamina. The mid-symptoms of vomiting and the diarrhea, I've read about cholera. I've never actually seen it, where, cholera is like a constant diarrhea. Ebola is like that. It completely strips its patients of any of their dignity. One patient really liked blue Gatorade, and his diarrhea was blue like the Gatorade. It is that fast. And then there's the rash. You definitely will see that, and then the confusion. And of course, the late stages is difficult to come back from that when they're in multi-organ failure and they're bleeding. There's no cure. There are investigational drugs, and it was well publicized in the media that we were giving them. There's three main ones. There's the Tecmira, the Brincidovir. I'm pretty sure these companies make these names up, so we can't say them. And then there's ZMAP, and each one works in a different way. And of course, there's convalescent serum. And convalescent serum is when you have someone who gets Ebola, they develop their own antibodies. So once they've recovered, you take their serum and you give it to your patient, and you hope that that's going to help the person recover. There's also a vaccine, and we weren't able to give that to our patients, but that's in Africa right now, and hopefully that is going to work. Got a lot of hope in that. And of course, then there's supportive therapy, so replacing fluids, giving them nutritional support, and treating their symptoms. Our team are, as I said before, they're nurses. They're all very, very good at what they do in their day-to-day jobs, but they do have to apply to be on the unit. We don't just take anyone. And once they come for a formal interview and we, think that they're going to be a really good fit, then we get them trained on how to work in the unit. We don't have to train them how to do their jobs, though. Am I doing for time? So again, was it anything that we expected when we actually got a real patient? The answer to that is really yes and no. We did come up with a few surprises, but for the most part, we knew what we were getting. PPE, this is what we eventually landed on, and it worked really well for us. So we have 3 different levels. So level 1 is the blue gown here, and I did bring some samples over so that at the end of this, if you want to come and see what it feels like, or even see what it feels like to put it on, you're very welcome to. And then the level 3 on the right side, that would be the extreme. And then the level 2 in the middle is sort of a hybrid between the two. Anytime we put on PPE in the unit, and these are real pictures now that you're going to see, anytime we put on PPE, we always have somebody help us, okay? It's really difficult to tie bows in the back of your back properly, or to make sure that things are on correctly. So we have what we call a donning partner. That means that they're helping you don into your PPE. This person can help one person, or they can help several, as long as everybody's doing things all at the same level. Taking off PPE, we have a doffing partner. We never ever allow anybody to take off their PPE by themselves. Even though I've been practicing this for 10 years, I never do it on my own. You've got to have help. Before we get a patient, this is a picture is pretty exciting, and our patient is on the way. We know that within the hour, this patient is going to be in our unit. And this is what we call our pre-patient huddle. And so Dr. Smith, this is him right here, he's given us a little talk about what he already knows about the patient, what the symptoms are, what we can expect. I've already created the staffing list and decided who are the first nurses that are going to be in the room, who's going to be helping with the transportation, all those sort of things. And you can see we all get along with each other really well. This is a moment in time where what I want you to see here is that even though we have this patient in a room, it's only the staff that absolutely need to go into that room that are allowed to go in and take care of that patient. So in this photo, what you can see here is our Associate Medical Director, Dr. Hewlett. She's actually talking to the patient, and I had to blur his face out. But on the computer screen, she's got real-time conversation with him. And Dr. Smith is actually in the room doing the assessment and relaying the information to Angela. And the gentleman behind her is our critical care doctor. So he's helping to make decisions. So if they don't actually have to be in the room, then they're not going back there. In this picture, it's the same sort of situation. There was something going on in the room. And again, we've got our doctor at the screen watching. We've got Dr. Smith behind that. And we've also got our other infectious disease doctors off to the side. You can see one of our nurses here up front. She's getting orders. And that was a pretty intense moment, as you can see in there. Anytime you're in the room, so this is the opposite side of that picture. So we were actually getting the room ready, but I used this picture to show you that it works both ways. So inside the room, you have the same size computer screen. So the patient is actually able to talk to the doctor or the nurses, or the nurse in the room is able to talk to the nurses at the nurses station very well. You can have voiceover or you can chat. It's like Skype, but it's a HIPAA-approved Skype, so nobody can break into it. All our staff, before we leave the unit, we always shower. We get out of our PPE. As you can imagine, we're always very hot and sweaty, and that shower is probably the best shower that you have ever. But we're doing it for an infection control measure. So once you get out of PPE, you shower, and then you go outside. And this is our shower. We provide our staff with whatever shampoos, body washes that they want. We also provide them underwear, and that's not necessary, but we found out very early that our staff were throwing their underwear away because they just felt better not taking anything home, so the hospital started buying it for us. Our shoes, the hospital, we also provide shoes for our staff. So they put them on when they get inside the unit, and they take them off before they leave the unit. And before they get put away in the cubbies again, they get bleach dipped twice and then hung to dry. So you don't ever have to worry that our staff in the biocontainment unit are walking around in shoes that they walked around inside the unit when they were taking care of a patient, because it just doesn't happen. They don't leave. We also have a shower set up just in case, and thankfully we've never had to use this one. But this is for just in case there's a staff emergency. So say a staff member was to get some body fluids on their skin, then we would get them out of PPE immediately and then get them in the shower and then get them some treatment. This is a picture of the unit where you stand and you put on your PPE in the warm zone, the clean zone area. Then you look down. This hallway is 67 feet, and this is the view from the other end. So looking from the patient room down towards where the nurses' station is. This is the clean room. That's the room I told you about that has all the equipment in there that we don't want to get dirty until we absolutely have to. And this is, again, another picture of our staff showing each other how to use equipment. So on the right, you see this is a respiratory therapist, and he's shown one of our ICU nurses how to use a ventilator. Now this particular ventilator, it works, and it works very well. It just got retired about 5 years ago when the hospital bought all new ones. So instead of throwing them away, we put them into a warehouse, and our respiratory therapists, they stay current on how to operate it. So when we need it in the biocontainment unit, you don't have to worry that our patient is using a ventilator that is eventually going to get used for you or any of your loved ones in the hospital. Not that it would matter, because it gets completely decontaminated anyway. This is the lab I told you about. So this hood over on the right side, that's a biological safety cabinet. So they're able to take the patient's blood, that's contaminated with Ebola, put it in there, open it up and spin it, and then perform all the lab tests for us. So now we're able to get all our lab results very, very quickly. And we actually put this in during our first patient that we had. The dirty room, as you can see, the dirty room is not very dirty at all. It's very clean. Very clean, very orderly. It's always nice and tidy. One skip is for linens, the other one is for trash, and is really just a staging place for it before it can go to the autoclave to get sterilized, which this is the autoclave. And as you can see, our autoclave person wears a full level of PPE that we wear when we take care of our patients. Because they touch potentially dirty bags of trash and linen, they can't mingle with the rest of the staff. So they get to put the PPE into the autoclave, start it, and then they clean the autoclave off with bleach, and then they sit on a chair. And the funny thing about this chair is we used to call it the dirty chair. It's not really dirty, but we just called it the dirty chair because we were worried that the autoclave person could be dirty. And it's the most boringest job ever, because he would put the stuff in the autoclave, sit for about 30 minutes and wait until we knew that we could take it out on the other side. So we gave him a basin and we filled it with magazines. So you know what we called the magazines, right? They were the dirty magazines, but they were really good housekeeping, Women's Own and things like that. This is the other side of the autoclave, and what I want you to see here is how we keep the community safe from our things that come up. So although you see our nurse, she's looking in the pen and she's got this little piece of paper in her hand, that's actually a steri gauge. So that's telling us that the autoclave reached the temperature that we wanted it to. And actually, before she even opened the door, she checked the printout to make sure that it ran correctly. And then it's hard to tell, but on the bag here, there's white tape. And when you put it in, it is all white. And then as long as the autoclave reaches the correct temperature, it creates little black lines on it. Okay. We also check the autoclave once a day in the morning. So we have the little vials of, it's got like a bacteria medium in it. So you run that through the autoclave and then you make sure that that's dead and it completely works before we even use it for any waste or linens. And as for linens, again, you never have to worry that any patient in Nebraska medicine is using the same linens as any of our highly infectious disease patients. So a long, long time ago, our hospital decided that anytime there was linens that was beyond repair or was stained and they couldn't get the stain out, then they would dye it blue. And then they stored it in a warehouse where it's always there for a public emergency. So it could be an ice storm or anything where linens are needed. And so we use it and then we throw it away. It's already revenue that's lost to the hospital, and it's special for us. So we use it as linens and then we treat it as trash afterwards. Okay. This is us setting up a room before a patient arrives. This is if the patient was going to have dialysis. This is just to show you that we actually even treat that waste. Even though it's been proven that waste from a dialysis machine, none of it has Ebola in it. So the CDC did tests or Emory did tests when they had their patient, and there wasn't any Ebola virus in their effluent, which is the waste from the dialysis. And we did some testing as well and didn't see any Ebola virus, but we still treat it. We disinfect it before we go. And this is what a critical care patient would look like in the hospital. Now, this is obviously a mannequin, but you can see that they would have to have the ventilator and the dialysis machine. You've got all these tubes, you've got the pumps. The two computers in there, that's there so that the staff could have one computer, and then the patient has a computer as well. And we're able to use that same video system for them to talk to their family. Am I running over? We're also prepared for this. We hope we never ever get to have this, but if we did have to take care of pediatrics, then we have some specialist nurses that are going to work with us and doctors as well. This is how we protect high-value equipment in the patient room. And this is an ultrasound machine that was actually being used while we were putting in a central line, as you can see here. The other thing to notice in a picture like this, so when a patient's having a central line put in, and I don't know how well you can see the picture, but you can see that there's blood on his hand and pretty, risky situation going on there. We also have to protect the patient like you normally do. So if you're doing a procedure that normally has to be sterile, like putting in a line into a vein, then you still have to make sure that the patient's protected from anything that could be on the outside of your regular PPE. So this physician and this nurse has got two sets of PPE on. They've got their PPE on that protects them from the patient, and then they have to put on another set sterilely on top of that. And that can come off when the procedure's done, but it's very, very hot, very stressful. This is how we protect the X-ray machine. It's a portable X-ray, and it's digital. So we were able to bring in the radiology technicians, and they help us assist them. They never get to touch the patient or anything that actually touches the patient. As you can see, the nurses would do all the work, and then the X-ray technician does their part, which is highly skilled, and there's just no way we could learn that. This is a stethoscope. So it looks like it's just a little puck, but it's a digital stethoscope that we put earbuds in when we're putting on our PPE, and then we plug it in when we go into the room, and then the earbuds are taken out without touching us, and then they're disposed of, and it's just a one-time use. Not everything is high-tech in our unit, as you can see. So our cafeteria started wondering where all their trays went, but actually, we just have one. Rather than use the toilet lid, because then there would be space, we found that the best way for us to flush the toilet, and we do treat the waste before it even goes in there as well. But we put a cafeteria tray on it, and when we flush, after it's settled, we are able to pick up that tray and then bleach it, and it works really well. This 10 years ago, when we first opened our unit, we were so proud because we were going to be able to plug this thing in. It's called a StarView telephone, and the patient would be able to talk to their family on one just like that. And it wasn't very good. It was almost black and white as well, and grainy, and it was hard to hear, but we thought it was great. Now we have this, and so the patient also has that way to communicate with their family. We have a command center set up at all times. This is a very quiet moment. It's usually very full of people. And then for the patient's family, we put them in a room. They get a hotel room, but they also have a room that's 2 doors down from the biocontainment unit itself. So they're pretty close to their loved one, but they can't come in and visit. We don't allow that. Before a patient can go home, they have got to have 2 negative blood tests for having Ebola. And it's got to be 24 hours apart, and they have to be done at the CDC. And then once we know, from the moment that we get our patient, all our staff are monitoring their health. So they have to take their temperature twice a day. And then after the patient goes home, they monitor their temperature as well for 21 days. And that gets reported to public health. The unit gets a thorough cleaning. We let it dry first because we know that Ebola can only live for about 6 hours on an environment, on a surface. And so we let it dry, and then we go in and we bleach everything. There's lots and lots of bleach used in the unit. And that's all I have, and I'll just wait for questions. Sorry I ran over.
We'll do questions at the end. And now we'll have Dr. Fornander.
All right, well, glad to be here, and thanks for coming. My perspective with infectious disease, obviously very different than Kate's. Luckily, we don't see Ebola in our clinic, or I may not be here, so that would not be good. But when Lori asked if I would come, I said I could certainly talk about what I see as a family physician in Lincoln. So growing up in western Nebraska, small town, my exposure to infectious disease was when they sent my best friend over when I was in kindergarten because he had chicken pox and my mom wanted me to have it. So that, that was about it. We didn't really ever think about it. Went to the doctor, got our shots, but I don't even remember getting flu shots or anything like that. So through medical school, then you learn about a lot of diseases that we see all over the world that you'll never hear about or see ever again, although now we are seeing a lot of these things, but Ebola wasn't even on that list when I was in medical school 14, 15 years ago. So definitely a lot of changes over the years. So I practiced about 10 years. The time I spent in McCook as well, it was a population that really didn't see much foreign travel. Generally, every now and then a missions trip or something like that, but certainly didn't have to deal with all of the different things that we do, even in Lincoln, with a lot of immigrant populations as well as the foreign travel that we see now. And have never even seen a case of measles, which has obviously been much in the press lately. So it's something that we still get asked about on board exams and questions, and you think, why are we worrying about this, or why am I asked about this when I've never seen a case of it? Well, it's happened in Nebraska now, and certainly I guess the people that write the questions know what they're talking about. So I think Tim's going to talk more about some of the challenges we face, but as a family physician, some of the biggest challenges that we have, as I mentioned, the travel and more mobile society, some of the lower immunization rates, and having a lot of conversations with people about vaccinations. I think people, with the way you can easily look things up on the internet, and there's a lot of good information out there and a lot of bad information out there, and unfortunately a lot of the bad information gets circulated more than the good information, so we get a lot of questions about, well, I don't want my flu shot because this could happen, or I don't want to vaccinate my child because this could happen, when the chances of those negative things happening are extremely, extremely low, or are just incorrect information they've gotten versus all the benefit of getting vaccinated. Professionally, the guidelines are always changing for vaccination. Every year there's something new or a change, or the formulations change, and that goes for newborns all the way to nursing home, which is also, I guess, a challenge in family medicine, is trying to keep up to date as much as possible on all those different age groups. And luckily there's great websites, and you can look things up on the CDC website and other immunization information that makes that a little easier. Plus just having a great staff in our clinic that keeps up to date, and we have things posted all over to help us with that. And one of the other things we dealt with recently, especially in the last couple months, is all the insurance changes going on, and the vaccinations can be quite expensive. Like a single vaccination for shingles can be over $200 if your insurance doesn't cover that. So there's a lot of elderly people that don't have $200, so you have to be very careful how you order it and if it's covered, and make sure you do things right. Fortunately, a lot of the good changes with insurance in the last year has been covering more preventive health issues, so it is easier to get a lot of the vaccinations covered than it was even a few years ago. So the things that we see most commonly, everybody here has heard of influenza. I think a lot of people have some concern about getting vaccinated, but a lot of the questions I get about why to be vaccinated is, well, I got the vaccination and I got sick anyway. I got influenza from the vaccination. Those kind of things come up, and it can be difficult because there's so many different things that can act like influenza initially, and symptoms can be similar with many other viruses and colds. It's really, there's no way you get influenza from getting the vaccination, but certainly it doesn't protect everybody. This year it was about a 50-50 chance of the strains being covered. So we're still seeing this year people that did get vaccinated and are testing positive for influenza and are coming in with typical influenza symptoms. So obviously it's not a perfect system, but a lot of people don't realize, I don't get vaccinated and I miss work and I give it to my child, and I'm out of work for a few days, I have an office visit, so all of a sudden the cost for that flu shot of, $50 to $100 is definitely exceeded by all the pain and suffering you've had, plus the cost of missing work. And a lot of people don't realize that influenza does kill people every year. We have serious cases in Lincoln every year, and also it can cause pneumonia, nervous system complications, heart complications, a lot of things that are more serious than what we would typically think about, just the aches and fever that most people get. Also, more people getting immunized definitely protects that spread to other people that are more vulnerable or cannot get the vaccination. So just definitely encourage people to reconsider if you don't get immunized for influenza. Another new one for me this last year has been all the pertussis and whooping cough. And that's something that just never really saw much in McCook, maybe a couple cases in 7 years. We suspect one of my physician partners actually had whooping cough, and he had a typical about 3-month cough, just really severe fits of cough. And it turns out he had seen a patient with similar symptoms, and this patient later on was diagnosed with pertussis. So that was interesting to have one of your own partners have that and not even realize it for weeks that that's what he had, because we just weren't seeing it very often. But that's something that has been a challenge as a family physician, because we're getting phone calls from kids that went to school and may have been exposed to pertussis, or pediatricians diagnosing pertussis in a child, and then we get a phone call from the parents about, I need to be on azithromycin or another antibiotic to help prevent the spread of this. And when that first started happening, I was pushing back a little about, wow, I haven't seen these people or for this issue, and the pediatrician is saying we should do this, and was, I'll admit, a little bit annoyed that they said, well, just call your family physician and get the antibiotics, because I get nervous about overuse of antibiotics and prescribing to people that I haven't seen for a long time, and making sure they don't have an allergy to that, or getting a message from a nurse from one clinic to a nurse in another clinic, and just afraid of missing information, especially on call when you're covering for a large call group as I do. But really with the CDC and their recommendations, in researching that, and I had to do a lot of reading to find out for myself too what's appropriate, and the health department is great about sending information out about how to best handle these situations. And so just having a comfort with doing that, because people are going to, as long as they're not immunocompromised or have some other underlying health condition, will recover from pertussis just fine for the most part. But you also have to think about the spread to infants and people that don't have their vaccinations yet. So a lot of factors go into that. But when you're communicating with, say, an obstetrician office and a family physician office and maybe a pediatrician office, it can get very difficult in knowing what to do and how far to go through families and how far to go through exposure. So it's been fun to learn those things, but also a little challenging and time-consuming in a busy office. One of the things I've never seen, such as measles, we were talking about this before, and so Tim could certainly speak to this issue more than I could, but the difference in infectiousness, looking at something like influenza, which maybe a quarter of people exposed will get, versus measles, where a couple studies I was looking up, almost 90% of people that are exposed and have not been immunized could get the illness. So highly infectious, especially compared to other diseases, and all the serious complications that can come from that. And then all the concern about the MMR vaccine and its a potential link to autism, which has definitely been shown to not be true over many years and many studies, and it's a very safe vaccine. But we still are getting a lot of questions about that in the office. I'd say a couple people every year still ask me about that. And fortunately, in this area, people are great. If we educate, explain that the information out there is not true, and show them studies that have proven the safety of it, I think that's helped a lot. But hopefully, with the great work of the health department and other people, we're not going to see bigger outbreaks of that. But once again, as more people choose to perhaps not vaccinate because of religious reason or just fear of the vaccination, we may continue to see those diseases popping up with all the foreign travel that we see now. And then one of the issues that we see, such as with the antibiotic prophylaxis for other diseases going around that can make it challenging, is seeing diseases like Clostridium difficile or C. diff. That's something that is becoming more common and also more difficult to treat. And that's a overgrowth of bacteria in the colon that can lead to what we call colitis, but also can lead to diffuse infection in the body and even death if it's not treated. And that's something, when I came out of residency, we saw every now and then, and we would treat it with a specific antibiotic called metronidazole. People put them on that, typically get over it pretty easily. And just in the last 10 years, we're seeing a lot of people that particular medication is not working anymore. So now we're having to go on to vancomycin, which is a medicine 10 years ago that we were told don't use that unless you absolutely have to, because you're going to use it too much and then bacteria will be resistant to that. So now we've even gone so far as having to treat this with fecal transplantation, where they take stool from another person and put it in your colon just to treat this disease. So talk about extreme. Not too many people think that that would be a very pleasant thing. Of course, you don't have to swallow it or anything. So, but just to think in the last 10 years or so how far that's come, and that's actually that the fecal transplantation is highly successful, and luckily vancomycin will still work in most cases. But just recently having a case of this in the last 6 months with a patient that did get severely ill from C. diff, and luckily the vancomycin worked, but you could see how this could get very serious very quickly in somebody that's maybe got some other health problems. So it comes back to how much do you conserve antibiotic use and following guidelines for preventing other disease, and then also having discussions with people about, if you do have a viral illness, that putting you on this antibiotic and then I give you C. diff because of that antibiotic, where it kills off the good bacteria and the bad bacteria grow, can be a time-consuming discussion. And just to have the awareness out there, there's often other reasons we may not be as open with the antibiotic prescriptions, because we do fear other things are going to be even worse than the viral illness that you have. So I think that's kind of just the basic things that we see. There's, of course, something new every day. We talk a lot about if something like Ebola walks in the door, or measles, that we really it'd be difficult for our staff and ourselves to even recognize it, because we're not looking for it, we're not educated on it. So just having more awareness and do the best we can to keep up, and people like Kate educating and getting the word out. We probably learn as much from the media on things like Ebola as everybody else, but we just try to keep up as much as possible, and the health department does a great job of sending out bulletins when things are coming up, so that's very helpful when you're trying to keep up with so many different things. So,
Thank you.
yeah.
Well, let me talk to you about where public health fits into this. The way the public health system, in terms of communicable disease or reportable diseases and condition, is set up, basically each state has statutes and rules and regs that require reporting of certain communicable diseases, conditions, illnesses, and situations or events to the local health department or to the state health department. And so think of this as kind of a mountain. And at the bottom of the mountain, at the lower end, is the local health department. And what we do on a daily basis, 24/7, is handle those reports that come in and do follow-up on many of those. And we collect a lot of data. We're looking at what's normal, for our community, what we normally would see in our community and we can expect. And we're looking for what we call red flags, things that are, something isn't right here. We shouldn't have, 5 or 6 of these cases reported in the last several days. We only see maybe 3 or 4 a year. Something's going on here. Those are the kind of red flags we're looking at. So we collect a lot of data. We're looking at trends. What's the trend? Where is certain diseases going? Who are they affecting? And so on. So we're looking at, in our case, Lincoln and Lancaster County, and what's happening in Lincoln and Lancaster County, and taking all that data that's coming in and evaluating it and processing it and following up on a lot of those. That data that we get and those follow-up and the information that we get gets fed to the state, and at the state level, they're doing the same thing we do at the local level, only they're looking at the state as a whole. And they're looking at all this data, knowing what's normal for the state, and looking for red flags at that level. So they've got a little bit bigger view than we have. So what may not seem out of place for the number of cases we have in Lancaster County, when you add it to what they're seeing at the state level, it may raise a red flag that we wouldn't see at our level. The data, that information that's gone from the local to the state and that the state gets from the health departments around the state gets sent to the CDC, de-identified. It's not got an identifying information, but that all goes to the CDC. So now you're at a higher level on the mountain, and you've got a broader view of the whole country, and they're looking at regions of the country and looking at the data that's coming in terms of number of cases of this, number of cases of that, and they're looking for the same thing, red flags. They know what they would normally see at different times of the year and what they are seeing and looking for those red flags. And then you can even take it another step to the World Health Organization, WHO. They're looking globally and getting information and trying to track where outbreaks may be going on around the world. So at each level, you've got a bigger view. The key, and the system works well, but the system does not work at all unless information comes into the system at the lower level. And that's where the key piece of this whole system is the frontline providers, the physicians, nurse practitioners, PAs, the hospitals, the laboratories, feeding that information into the system, reporting those things that are reportable, and also those things that are not reportable that are out of the ordinary. You're seeing individuals, a high number of individuals with certain symptoms. You're not sure what it is, but something ain't right here. Letting the health department know of that. And once that gets into the system, then the system works well because it handles that. It moves on that. It gathers more information, and it starts to identify what may be going on. It may be nothing, but it may be something. But if that information doesn't come into the system, nothing's going to happen. And that's the key to communicable disease control and prevention is early identification. If you don't know you have a problem, you're not going to be doing anything about it. So constantly looking for things that are not normal. I'll give you going back, using back in early 80s with HIV. Well, in the early 80s, we didn't know it was HIV. But the way the system worked was on the East and the West Coast, physicians were seeing young males who were coming down with these what was called opportunistic infections caused by organisms that typically don't cause infections in humans. But these individuals' immune systems were not functioning. They were weakened, and they were dying, and nobody knew why. And that information got sent up through the channels to the CDC. CDC started to look at this and then put out across the country to providers through the state and local health departments calls for cases, identifying back to the CDC through the local health departments if they also are seeing this kind of syndrome or symptomatic individuals. And that, of course, led to, we've got a problem. And that kicked in the process of trying to figure out what was going on here. But that wouldn't have happened if that information, or would have happened eventually a lot later, but the earlier the better, getting that information into the system. So that's important. So the key to the whole public health system is information. Data is important to us. It helps us identify early that we got a problem so we can kick in and start doing something about it. Over the years, in my career in public health, I've gone from HIV and AIDS in the early 80s to anthrax, through SARS and all kinds of other stuff, including pandemics. And some of the things that I learned, lessons that I learned through this is communication is key. Again, communicating into the system, but the system in terms of public health, communicating out to other partners in public health, to the state, to CDC, communicating information, sharing information, but also to providers in the community. As was mentioned, if we know something's going on in other parts of the country that may show up here, getting that information out to providers so they're aware of it, so that when they're looking at patients, they can think about, well, I've got this information that this is going on. Is this a possibility? Put it into their list of things to rule out. Increasing their awareness level. You can't make the awareness level for every possibility high in providers. There's just no way. There's just too much stuff. But if something is happening anywhere in the country that may affect us, getting that information out to providers in the community is important. The other thing is getting information out to the public. What's going on in the community that may affect them. If we've got something going on community-wide, we want to get that out to the public, get factual information out. With a lot of stuff that can happen, like with AIDS in the 80s and then anthrax in the 2000, 2001, and then with the pandemic. A lot of, when there's stuff that's out there there's a lot of unknowns, there's a lot of public fear. And it's important that public health get factual information out. We may not have all the information, but the information we have, we need to get out to the public so they have factual information. And we need to be able to say, we don't know yet. Because I remember with HIV, back when in the mid-'80s, when there was a lot of fear, and that can affect not only individuals, but workplaces, schools, the whole public in general, and society in general, that fear. And going out and talking to groups, and people would say, well, can it be transmitted by water, drinking fountains? Can it be transmitted by touching somebody? And in the mid-'80s, we had just identified what was the cause of AIDS, HIV. But we were still studying how it was being transmitted. And so we had to say to the public, probably not, because based on what we knew so far, it didn't seem to be. But we couldn't say for sure because the studies were not done. And that's a challenge, because if I say to you, probably not, you're going to say, well, then you don't know, so I'm not taking any chances. It wasn't until later in the 80s when the studies were done and showing that, no, you don't get it this way, that we could say to those questions, no, that's not the way you transmit. That's not how you get it. And that's reassuring. And it was so important to get that information out. But we couldn't wait until we had all of the information. The public was fearful and concerned, so we had to give them what we had, which may not have been what the best, that all the information that would have been helpful, but that's all we knew at the time. So communication is critical, and timely communication, getting it out. The challenge in today, in terms of communicating information out, is information gets out very quickly through Twitter, through the internet. So public health challenge is to try to get out there fast. And sometimes we want to get more information before we put it out, and we get behind in terms of getting information out. The other thing that I've learned is when you've got things like a pandemic coming that you're aware of, if you've got things like HIV and AIDS in the 80s, it's not a public health, it's not a health department problem that has to be addressed. It's a community problem that has to be addressed. It affects the whole community. The whole community needs to be involved in dealing with these kinds of things, these unknowns. And so what I've learned, the lesson learned, is to involve the community. With AIDS and HIV, the health department developed a task force made up of people throughout the community that would meet and be the central point in terms of education and information about AIDS in our community. With pandemic and planning for a pandemic, if you remember, prior to the pandemic, the world was looking at Asia and bird flu. And a lot of planning was going on for preparing for a pandemic. It turned out we were looking in the wrong direction. It ended up coming out of Mexico and not Asia. But we were prepared because we had brought in the community and we had sat down and figured out and come up with a community plan how we were going to address it. And we looked at, in doing that planning, at worst case scenario. So if it wasn't the worst case scenario, that's great. If it was, we had a plan. But it involved the community because it was going to affect everybody in the community, and everybody had to be involved, all areas of the community. So that was important. The other thing I learned was that we used to, when we were sitting down prior to 2001, doing planning for bioterrorism, we're thinking, well, look, we're in Lincoln, Nebraska. We're in Nebraska. What's the chances of us having something happen here? But we'll plan for it, but it's not going to really, if it happens, it's going to happen on the east or the west coast, some of those big cities, and it's not going to affect us. After 9/11 and then an anthrax showed up. The lesson learned out of that is no matter where any of this stuff happens, even though it doesn't happen in Nebraska, it's going to affect us. Because anthrax never even came close to Nebraska. But I can tell you, and I'm sure you remember, the fear levels in Lincoln, Nebraska. People were afraid to go out and get their mail. We were going 24/7 responding to calls about powder. People would find powder and they were afraid. And we would go out early, when this first began, and we would collect that powder and have it tested. So for about 2 or 3 weeks, anybody who called and said that they had a white powder they weren't sure of, they didn't know about, we would go out and collect it and test it. We had to because the fear level was so high. How could we say, don't worry about it? But after 3 weeks, and public health lab tested everything, and nothing was positive. We could say to the public, look, we've done all this testing, nothing, it was positive. So instead of testing everything, here's the stuff we're going to test now. And that was okay. But again, the lesson was no matter where something happens in the country, it's going to affect us somehow. Did with SARS, did with other stuff, it's going to affect us. So we've got to be able to address it. Even if it doesn't show up here, we're going to still be affected. And I'm going to end here with just a couple of things. One is it's the challenges that now and in the future is, remember, it's a small world, and people travel in and out of on a daily basis to different parts of the world and get exposed to things. We've got now, over the years, more and more congregations sending people on mission trips for a week or two, going into Central America, South America, other areas of the world. And there's stuff in other areas of the world that we don't have here, we don't see. And people may get exposed and bring them back, and we may see stuff that we don't normally see, and that's a very real possibility. We talked about antibiotic resistance. That's going to be a real challenge because we run out of antibiotics that work. We've got nothing. And then, you know, we thought we were done with some of these diseases, and we're seeing them come back. I'm going to end it there. What we want to do now is open it up to questions. People have questions for any of us on the panel, just raise your hand and we'll come up to you with the mic.
Can you comment on the action of those drugs and how they were attacking the Ebola virus?
Yeah, I don't have the expertise to do that. They're investigational drugs. What I know is that two of them, they inhibit the viruses from reproducing. The ZMapp has antibodies in it, but of course by the time we got our patients, the ZMapp had been used up. So that's about all I know. Sorry.
Thank you.
Kate, can you tell us how the culture changed at Nebraska Medicine or in the medical center at all after they knew there was a patient that had Ebola that was actually on the premises? I'm sure that they knew that was always a possibility, but once the patient got there, was there a change in culture at all?
Not really, but we've always been very transparent with everyone at the hospital that we're there, being open to people coming in and seeing the unit. So a lot of the people at the Med Center already knew the safety aspects that were being put in place. They had a lot of trust in the biocontainment unit staff. When we were getting a patient, the amount of support that we got from the hospital was just totally awesome. Our team came together as a team, and the entire hospital were there supporting us in every single thing that we did. It was really great to see.
I was just going to ask, what do you think is the biggest threat to Lincoln?
To Lincoln. Yeah.
Losing a football game, somebody said up here.
That would, oh, well, right now we're dealing with whooping cough outbreak. In public health, one thing I've learned is you never know what's going to show up. It's important that we do what we do in public health to monitor this, and it's important that we stay aware and communicate with our partners, both at the state and federal level, to see what's going on and be aware of what's going on in other parts of the country and other parts of the world, because the potential is there. That, as I say, SARS taught me, I didn't realize how many individuals go in and out on a daily basis for business to other areas of the world. Where measles is endemic. I mean, they have outbreaks all the time in places in Europe, where they can be exposed to all kinds of things. An example recently, this last year, we've had 4 cases of chikungunya. Whoa, what's chikungunya? Wow, we never heard of it in Nebraska either. But last summer, it showed up. And the reason it showed up is because in the Caribbean, they're having an outbreak of it in those countries in the Caribbean. It's mosquito vector, mosquito-borne illness that you get from a certain mosquito that bites you. And individuals come back and become symptomatic. They can't transmit it. Unfortunately, we don't have that type of mosquito here, but they do in southern part of Florida, and they have seen cases transmitted within the United States in that area of the country, but we don't have that mosquito here. But who would have known? So when a person shows up with symptoms, you're not thinking chikungunya. You can't even pronounce it. But that's the kind of stuff that can happen because it's a small world, and we could have people coming back, incubating. period of time from exposure to development of symptoms, coming back, because you can be on one side of the world and back here in less than 24 hours, and develop symptoms and show up. And if it's something we don't normally see, that's not going to be the first thing you're going to think about. You're going to think about the stuff that you're more apt to see locally. And then after you rule those out, then you're going to be looking for the zebras, the things that are uncommon.
And immunizations such as chickenpox and measles, are those always lifetime immunities?
Not always. They are effective, and I don't know as far as the research currently on varicella vaccination or chickenpox, since it has only been done the last 15 years or so, 10 to 15 years, what that will be long term. But it appeared that there wasn't going to be without a booster shot, so you give it to the younger child at 12 to 15 months, and then again at school age to try to boost that. Measles is highly effective, but some people still don't convert or have antibodies to that, so they may benefit from a third vaccination instead of the 2 in childhood. So do you have anything to add to that as far as?
I think, for instance, with chickenpox, I mean, we're seeing the impact. We used to have outbreaks in schools every school year, but we don't see that now. We see isolated cases a lot of times, but not what we used to see at all.
We still will see cases of chickenpox with vaccinated children, but there's usually just a few lesions or very minor. So that's what we see now. I haven't seen a overt case of chickenpox, I guess, since residency when we started vaccinating.
What are you doing on a provider level to educate people who are coming into you that are against vaccinations and immunizations? What are ways you're getting through to people?
That's a great question. We try to obviously educate as much as possible, but a lot of times if somebody has a resistance to vaccination, education doesn't always change that. So what we do, and with the patient-centered medical home model that we use, that Dr. Ellis, Michelle Ellis that I work with, and the clinic there, going through a process is reviewing, first of all, the patient's vaccinations at every visit. And patients sometimes get a little tired of filling out the paperwork every time about, have you had your flu shot? Are you up to date on your other vaccinations? Are you interested in a pneumonia vaccination? Are you interested in tetanus update or tetanus and pertussis update? So we try to, first of all, find out who needs those vaccinations. And then secondly, the medical assistant or nurse will say, are you interested in getting those vaccinations? Or here's a handout on the vaccination that you can read about. So the handouts that we give people before every vaccination really are good information. It tells obviously your benefits, also the risks, even though they're rare, such as you could get a fever, you could get achy, you could have a seizure, you could have all these things that could happen, even the very rare things. So that's the first thing, is identify them and give them the information. Then when we come in, if the patient says, no, I'm not interested, I will still ask them, hey, I see you declined to get the influenza vaccination. What is your reason for doing that? And often it's, as I mentioned before, people that say, well, I still got the flu, or this or that happened. And so I'll explore that a little bit. And if they did have a bad reaction or something that they're just adamant about, then generally I'll say, well, here's the information, read about it if you change your mind. The American Academy of Family Physicians recently sent out a bulletin with information about vaccination. And there's a pediatric journal that they quoted a study from that actually showed that kind of hard education in a clinic, when you're looking at parents deciding for their children, really wasn't effective. In fact, a little bit higher percentage of people, after getting a lot of information, actually declined to vaccinate their children because they're seeing all these horrible things that could happen when we're just trying to provide information, not scare people. So there's probably a good research to be done in that area of how do you get through to people. But I think for me, I always say, even if you aren't worried about getting this particular disease, whatever it is, if it's pertussis, influenza, whatever, the newborn grandchild or the newborn in your home, or the person in your family that's being treated with chemotherapy. These people that are immunocompromised or are not able to get the vaccination, or they have a true contraindication to it, or they've had a bad reaction, those people are very susceptible to getting disease. So thinking about those people, protecting yourself so you're not spreading it to other people and you're not at risk for making a bigger problem for somebody else. Sometimes that does actually work. And people say, oh, I never really thought about that. So does that answer that? Yeah. Thank you for the question.
Well, I want to thank you all for being here. I want to give you just a couple of reminders. If you want to watch this program again, or if you want to have someone in your agency or friend or a neighbor watch it, look for it on YouTube or on 10 Health TV. Would love to have you back for our next Community Conversations, March 26th at 10 a.m. I am a suicide survivor, so just sign up online like you did for this one. And we do have extra brochures. If you have a place to take them back to, your office, or if you'd like to hand them out to your colleagues or friends, please take some on the way out. And again, I want to thank the health department, our partner in this event, Tim, for moderating the panel, but certainly Dr. Fornander and Kate as well. You are terrific, and the amount of information you packed into this hour and a half has been extraordinary. So thank you so much. And I think you have some items that folks can look at here, Kate, if they'd like to. So feel free to do that as well. Thank you so much.